Hello and welcome. My name is Dr. Alexander Apkin, and you are attending Your Weight is Over Weight Loss Surgery Educational Seminar. On the next slide, you'll be able to see my practice surgical experience. I've been doing bariatric surgery since 1999. I am board certified bariatric surgeon with more than 6,500 procedures performed. My first band was implanted in 2001. My first railized band was implanted in 2007. My practice is designated in a Center of Excellence for Bariatric Surgery, and I've been named Top Doctor by New Jersey Monthly Magazine 7 years in a row.
Recent research is revealing the true nature of obesity, shedding light on one of today's most common questions. Why can't I keep the weight off? The traditional view that obesity simply results from a failure to maintain a healthy lifestyle overlooks how the body regulates energy. Recent studies show that weight regulation is a complex process governed by hormonal and neuronal signals between the brain and a system of organs and tissues. New research also reveals that as body fat levels increase, the body adapts and sets this elevated weight as a set point or a new normal. Since this new fat level is recognized as ideal, the body will attempt to maintain it. With this elevated set point, the body defensively responds to even modest diet restrictions by increasing hunger and cravings, decreasing satiety, and slowing metabolism, all to prevent starvation. As part of a basic biologic instinct, well preserved throughout human evolution, even an obese body is programmed to protect fat levels. Because this weight-regulating mechanism does not recognize obesity and subsequently does not allow the return to a healthy weight, obesity presents in patients as a chronic disease. Similar to other metabolic functions, such as blood glucose, LDL cholesterol, and blood pressure, body fat set points are affected by genetic predisposition, environmental exposure, and developmental history. Though all of these factors contribute, the recent epidemic rise of obesity can be primarily attributed to the modern environment. Negative changes include alterations in the chemical and nutrient content of our food, a lack of exercise, high levels of stress, inadequate and disrupted sleep, and the widespread use of weight gain-promoting medications. The result is that many individuals have become obese and, despite efforts to lose weight, remain so or even gain weight due to the compounding effects of metabolic dysfunction. For effective weight loss, calorie intake must decrease and calorie output must increase. However, the obese body treats a calorie reduction as a starvation threat and defends by conserving energy and restoring energy-rich fat. Throughout most of human history, calories were scarce and hard to get, so we have numerous natural defenses against starvation. We have no defenses against overeating because we never needed them. A landmark study of over 4,000 patients found that on average, fighting obesity with diet and exercise alone only achieved a 20-year sustained loss of 4 pounds. The New England Journal of Medicine reported that though dieters may initially lose weight, their bodies then encourage fat regain by triggering a cascade of changes in hormonal and neuronal signaling, which did not return to pre-diet levels even 12 months later. This unrelenting self-preservation mechanism may explain why most weight loss attempts fail in both the short and long term. Successful weight loss is important because obesity has been linked to increased risk for diabetes, an ever-increasing public health threat, as well as cardiovascular disease, the world's leading cause of death. Other diseases related to metabolic dysfunction have also been linked to obesity. The key to reducing these health risks and successfully treating obesity long-term appears to be treatments that change the physiological body fat set point. For many patients, this requires therapies that can deliver long-term weight loss of more than 10%. New research indicates that bariatric surgery, increasingly referred to as metabolic surgery, has lowered set points and had profound metabolic impacts beyond that of weight loss. The surgery changes hormonal and neuronal signals, decreasing appetite, increasing satiety and metabolism, and encouraging healthier food preferences. Positive weight-independent changes, such as glucose homeostasis, lipid biology, and more have also been observed. The New England Journal of Medicine reported that more than 3 times as many diabetics achieved glycemic control of 6% or less through bariatric surgery versus those who only underwent intensive medical therapy. This new data on the complexity of weight regulation, the concept of set points, and weight loss study results has shown that diet and exercise may not be enough to achieve the most advantageous long-term benefits for obese patients. In contrast, metabolic and bariatric surgery patients experience, on average, over 45% excess weight loss and lower body fat set points. This allows them to successfully keep the weight off, reducing their risks for a host of obesity-related diseases and improving the quality of their lives.
Today, over the course of presentations, you will learn about obesity, how to decide what qualifies you to be a candidate for surgical intervention, how expensive is it to be obese, and what are the surgical options do you have, and how do you make next steps to healthier, better you. And you also will see through the course of today's seminar video testimonials and animation videos which will help you to feel, hopefully, that you came to the right place today.
I suffered a fall approximately 3 years ago and didn't break anything, but had sprains. I had a sprained ankle, sprained knee, sprained back, had 2 surgeries, and as a result, I now have chronic back pain and hip pain. I have done everything, medically indicated, and now was at the chiropractor, and he thought by losing weight that would alleviate some of the pressure on my back. I didn't really take him seriously at first, but when I went back the second time, he started giving me brochures. I was like, okay, he's really serious about this. He wants me to really think about that. Then I had to kind of really think about the fact that obesity is a disease. That was something, a thought process that I just had never ventured to think about before, that this really is a disease and that I'm a person who is afflicted by this disease and have been afflicted by it since childhood. So that was kind of a wake-up call for me, that I needed to do something.
I think my wake-up call probably was when I realized that my quality of life was declining. And it was going down rapidly. I had diabetes. I had a lot of issues with my breathing, with asthma and joint issues, and life just was not a whole lot of fun to live anymore. So I realized that for me to be able to be there with my kids and to do things with my kids and to just enjoy life, that I was going to have to do something because I didn't want to keep going the way that I was.
I live on a corner house, and I was sitting outside with my son, who was just learning to walk, and we were sitting on the lawn and just playing, and out of nowhere he jumped up and ran towards the street. And the amount of time it took for me to get up and run after him, he was already in the street. And I realized that I wasn't there to protect him, that I couldn't do it at my weight. So at that moment, I knew that I had to do something so that I could be there for him. He was only 1 year old.
So the next slide shows how do we decide who is obese, who is overweight, and who is morbidly obese. We will focus today at the seminar at the category of morbid obesity called severe obesity and morbid obesity and supermorbid obesity. It starts at the body mass index of 35 and goes all the way to higher than 40, and 50 is defined as severe morbid obesity. So we will focus on those categories today because patients in those categories are considered to be surgical candidates by National Institute of Health accepted criteria. But we're also going to focus not just on numbers of body mass index numbers, but we're going to focus on what we call severe medical illnesses called comorbidities, which are typically associated with morbid obesity. And the next slide, as you are viewing it currently, depicts those comorbid conditions. Type 2 diabetes, high blood pressure, hyperlipidemia, sleep apnea, depression, menstrual irregularities for women, urinary stress incontinence, gastroesophageal reflux disease, joint disease, arthritis, and need for joint replacement, heart condition, fatty liver changes, stroke. All those conditions, which unfortunately some of you may have, are associated with morbid obesity, and unfortunately most of them are not successfully treated with maximum medical therapy, and at which point patients resort to last resort option, which is surgery. And surgery happens to be the most effective way of dealing with those comorbid conditions. And at the presentation completion, I will show you the slide summarizing the resolution of those medical conditions with weight loss surgery. And you'll be amazed, hopefully, and pleased that you came to the right place, that we can resolve those medical conditions or maybe completely have them go away altogether, depending which surgery you choose. And the next slide depicts the fact that you should not feel uncomfortable because you're not alone. 65% of the Americans are morbidly obese. 32% of children are overweight, and we have a huge epidemic of obesity growing in children population if we don't take care of it now. 5% of the Americans are morbidly obese, which means they qualify to be surgical candidates. This is a very deadly disease with more than 300,000 deaths attributed to morbid obesity or conditions associated with it. And it's a very costly disease to our society, estimated to have cost more than $147 billion in 2009. And as we well know, our society can't truly afford increase in health care. But how do we decide what is the cost of obesity versus affordability of surgery? First and foremost, we sure hope that insurance coverage will be available to you, and you will have a chance to have the weight loss surgery and get your life back, and insurance companies will cover the surgery. But when we decide on affordability, we have to consider how much it's costing you currently or have cost you already with all those diets and exercise and pills and what have you prior to coming here today. The next slide depicts a comparison of diet weight programs well established, such as Atkins, Zone, or Weight Watchers, and people who subscribe to the diet plan stayed in the program for a year. But as you can see in the red on the slide, that at the completion of 1 year program, if people completed 1 year program, they were only able to lose 5 to 7 pounds. Now, just to give you a perspective, if body mass index is 40, that roughly correlates to 100 pounds over the ideal weight. So if my patients need to lose 100 pounds to get their weight to normal weight and lose 5 to 7 pounds, you can see how they'll be frustrated, upset, and unfortunately that usually leads to improper coping strategies and possibly to additional weight gain, not weight loss. On the contrary, surgery is associated with at least 50% of excess weight loss, if not guaranteed, but at least closely to that guaranteed, if the patients come to the practice, which is considered to be a center of excellence in weight loss surgery. So therefore, no questions about it, weight loss surgery offers much more sustainable and durable weight loss compared to established diet programs alone, listed here. Also, when you decide on a personal cost of obesity, you have to consider other additional costs, such as over-the-counter medications costs, co-pays for doctor's office visits, co-pays for lab work, co-pays for specialists, grocery and dining costs, out-of-pocket healthcare expenses. All those extra costs quickly add up, and you may realize that surgery alone may be not that expensive if there's no insurance coverage, because you're already paying too much and you really can't afford it. And more importantly, if your body mass index is 35 and above, which means you are a candidate for surgical intervention if you have comorbid conditions, the next slide shows that your additional healthcare cost will be approximately 44%, which means you'll be paying more, and which means the whole society eventually is paying more. And by doing something about your weight today and doing something about your health issues today, you're taking next steps to reducing healthcare utilization and actually cost of healthcare for yourself and for this country.
I have relatives that have high blood pressure and diabetes and all these health issues. And being 51 years old, I'm certainly concerned about those issues. I do not have those issues at this time, did not have them before the surgery, and don't want to get them. So I have to make some life-changing decisions.
Everyone in my family is very tall and has been overweight, and my grandmother passed away of pancreatic cancer, and so we knew that that was mostly due to her being overweight, and we realized that was not the road we wanted to go down. And so my mom and I both decided that this was an important decision for us to make, and it's been the best decision that we've made.
What really inspired me to really get my life under control here, a couple of years ago, my mother had a heart attack. And she stayed in the hospital in ICU and in a room for 73 days. And my family and I, we watched her die on a ventilator. She had, all the comorbidities, hypertension, high blood pressure, significant weight gain, diabetes. She had all that. And I looked at her and I thought, look what my family's going through. And then I looked at my son, I thought, I cannot do that to him. I cannot do that to my son when he's my age.
Now, in case we find out that your employee excluded weight loss surgery coverage from availability to you, and my insurance specialist will be able to verify that upon completion of that seminar, I don't want you to think that you cannot get your surgery today or you cannot get your surgery tomorrow. The next slide shows that actually patients who decided to exercise what we call a self-pay option or finance their surgery, and the only person who can make that decision is you, because you know what your health costs are to you currently and whether you are at risk for sudden death or worsening of your diabetes or sleep apnea. Only you can make that decision. But if you decide that your health is worth it, the next slide shows actually that you will be saving money because your decrease in food costs and clothing costs and healthcare costs comparing to the cost of monthly payment for the surgery on a lease for 5 years is approximately $200 a month of saving. So quite frankly, you will get your life back, your health will be improving, and you'll be saving the money. So sounds like a good deal to me. We're going to move on to the surgical options, and I presume that's why you're here today. In order to be a candidate for surgery, as I already emphasized on several occasions, you need to meet the criteria to be considered a surgical candidate, which are body mass index of 35 with medical problems or 40 without medical problems. You need to be healthy enough to undergo surgery, which means we'll ask for your medical doctors to get us what we call a medical clearance. And 99.9% of the time, that is not a problem. So I don't think that we have to be concerned too much about that. Obviously, insurance companies would want us to prove that you tried non-surgical weight loss attempts. And most of the time, we'll get records from your Weight Watchers, records from your doctors, gym membership, what have you. So typically, this is not a problem. Obviously, you need to be free of drugs and or alcohol because food is an addiction as well. And patients who have two addictions will have to enter counseling before considering weight loss surgery. You also have to have no uncontrolled psychological conditions, and that's the reason why we emphasize need for psychologic screening prior to surgery. And you need to be able to understand surgery has its risks, not just benefits, and be able to execute and sign informed consent. And attending and listening to that seminar today is a perfect starting point for some people to make sure you understand what those risks are all about. And last but not least, I believe in comprehensive, dedicated to lifestyle change, lifelong maintenance of surgery, not just quick fix of surgery as some people might think. And therefore, our program is comprehensive, and we'll be glad to see you for as long as you're willing to come. And that usually translates with much better outcomes long term. Next slide shows three most commonly performed bariatric procedures which are accepted in the United States of America currently. Gastric banding is considered to be a restrictive procedure. The next procedure is called sleeve gastrectomy. This is a stapling procedure which considers to be restrictive, but weight loss is similar to the next procedure called gastric bypass, which combines restriction of the small pouch with bypassing a portion of the small intestine, adding to some malabsorption of nutrients and calories, and therefore improvement of weight loss. So we'll talk about those procedures one by one, and I'll also show you video animations of the procedures to further explain those procedures. Before we go into procedures in detail, I always like to have patients set their what we call realistic expectations, what to expect, what will happen if you choose one procedure versus another. So the next slide shows comparison of gastric bypass, gastric banding, and sleeve gastrectomy. As you can see, gastric bypass, we expect patients to lose more weight, and some patients lose nearly 100% of the excess weight loss, and they keep it off for a long period of time. Gastric banding, the expectation is that they will roughly lose 45 to 50% of the excess weight. And gastric sleeve or sleeve gastrectomy, the expectation is 60 to 70% of excess weight. So it sounds a little better than a band, but slightly less than a gastric bypass. So we'll go one by one now, or different procedures. Adjustable gastric banding is a procedure which is popular because of the fact that it's least invasive. It's outpatient procedure, therefore return to normal activities is faster, and yet it's combined with an excellent weight loss. At 1 year, patients lose about 40 to 42% of their excess weight. So it's roughly 40 pounds for somebody who is 100 pounds over the ideal weight. And this has very low risk of complications, therefore it's appealing to people. Yet, on the other hand, you have to expect that this mechanical device, the implant, and I'll show you that implant. This is right here. This is one of the bands. So this is what it looks like. The band and a port attached to it. So that device will have to be implanted in your body and will be in your body for as long as it needed to be, as long as there's no complications. And if some people are not comfortable with the fact that they have to carry that device in their body, then obviously the banding procedure is not for them.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced into the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch decreases the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
There are two brands of the band available to United States consumers on the market as depicted on the next slide. One of them is called Realize band, and it's manufactured by Johnson & Johnson. And one of them is called the Lab band, which is manufactured by Allergan, and it was made available in the United States in 2001, and the Realize has been made available in the United States in 2007. They're both FDA approved, they're both safe, and therefore It's really a decision of the consumer to choose which brand they want to have. And when you come to the consultation, I'll compare it side by side, and we can help you to make that determination of which brand you think fits your profile better. The next slide shows that unfortunately banding surgery, although least invasive, is not without possible complications. And the risk of those complications listed on the slide is in the range of 1 to 5% over the lifetime of the device. So let's go over those possible complications. The pouch above the band can dilate, which means the patients may lose sensation of fullness and the hunger cravings will come back, and therefore the band may have to be repositioned, deflated, or possibly removed. If the patients exhibit a lot of signs of vomiting or what we call maladaptive eating behavior, the band may slip. And when that happens, patients have symptoms of acid reflux, regurgitation of food, and the band needs to be deflated, revised, or sometimes removed as well. In a very small percentage of patients, the band may migrate from outside of the stomach, where we implant it, to inside of the stomach. And that complication is called band erosion. Interestingly enough, this complication typically has very few symptoms, and it usually is discovered incidentally on endoscopy by gastroenterologists. Obviously, if that happens, the band will have to be removed and the stomach allowed to heal, and then either additional band can be implanted or the band can be converted at that point to another type of weight loss surgery. The next slide discusses the band adjustments and how we do it and what to expect from band adjustments. Typical weight loss for the banding surgery is 1 to 2 pounds per week. So therefore, the decision about when to do band adjustment is made if and when patient's weight loss is below that curve, or they feel that the portions are not controlled by band tightening. The adjustment is usually very easy to do, takes 5 to 10 minutes, and typically can be done right in the office setting. But occasionally, or at least once a year, we will do band adjustment under fluoroscopic guidance in the hospital to make sure that we document that the band has not migrated and nothing has changed. And typically, in the first year after surgery, the typical patient will have 2 to 4 band adjustments. And the second year, patients will have 1 to 2 adjustments. And by the second year, patients will lead a normal life and get to their expected weight loss. And therefore, at that point, the band maintenance phase begins, which means periodic visits to the doctor, barium swallow or x-ray once a year, and occasional band adjustments, but typically that may not be necessary. But maintenance and annual visits to the doctor are strongly recommended to prevent possible complications. The next slide shows the procedure called the vertical sleeve gastrectomy. As I already mentioned, this procedure is considered to be restrictive, but behaves closer to gastric bypass when it comes to weight loss, and possible complications of that procedure are similar to possible complications of the gastric bypass because it's a stapling procedure. It is a very good option for carefully selected patients, and it carries excellent weight loss at 1 year, which is roughly 60% of the excess weight, or 60 pounds weight loss. And there's no implantation of mechanical device such as bands, so therefore patients who don't like the foreign bodies may lean towards that procedure. And you will see video animation of the procedure next to understand the procedure in more detail.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. by altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
The next slide shows possible complications of the sleeve gastrectomy. As you can see from that slide, the complications are slightly different comparing to the complications of a gastric banding procedure. Obviously, the stapling procedures may lead to more nausea, more dehydration, and more importantly, if something goes wrong with those staple lines and they break down, they can leak or the stomach can get obstructed. The leak rate for sleeve gastrectomy quoted in the literature in practices which are considered center of excellence is 0.8%, which is very low leak rate. But I wish I can tell you that we can make that leak guaranteed to be zero. Despite our best efforts, despite of us testing the staple line integrity at the completion of the procedure for a leak, it still can happen. Now, you may ask me a question: how do you guys check to make sure that the staple line is intact? And I can tell you, for all stapling procedures, I do what is reported in the literature or widely accepted as a bubble test or a leak test via performance of the endoscopy. So during the procedure, at the completion of the procedure, I will pass the endoscope through the mouth into the stomach, and we'll submerge the stomach underwater, and we'll blow air under pressure, and we'll look for bubbles to come up to see if there's any staple line dehiscence or popping out in any of the areas. If we see that any of those staples are not watertight and we see where the bubbles come from, I take a suture and I suture that area, and then I test it again. So the rule of center of excellence practice is that the leak test needs to be done, and the leak test has to be negative or the patient cannot leave the operating room. So I try to make sure that my patients are safe, because obviously that's number one of my priorities. In addition to the concern about leak, people always concerned with weight loss surgery, can the stomach stretch? And if we calibrate the staple line and the pouch properly, and we calibrate the size of the sleeve or gastric bypass 100% of the time by special calibration tube, the chances are that the stomach would not stretch, and therefore the weight loss would not, the weight loss will last for a long time, and weight regain would not happen. But again, as I emphasize the need for lifelong follow-up, patients who come on a regular basis have much higher chance of sustainable weight loss and fewer chances of weight regain. And for not just for sleeve gastrectomy, but for all weight loss surgeries, I emphasize the need for vitamin and mineral supplementations for the rest of the life, and how much of the vitamin supplementation needed will be determined by the blood work, which my patients do once every 3 months for the first year and once a year thereafter. The next procedure is a laparoscopic Roux-en-Y gastric bypass. It is considered gold standard, and the reason why it's considered to be gold standard because it's been done for a very long time. We're coming on 30 years of the procedure. It's been done laparoscopically for 20 years, and it's an excellent procedure with excellent long-term track record and very few complications. As you can see in that slide, expected weight loss at 1 year is 67%, or almost 70 pounds in 1 year, and there are no implantation of the mechanical device and very few complications. And I'll show you the video animation of the procedure next.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So what are those possible risks of complication of the laparoscopic gastric bypass? As in the vertical sleeve gastrectomy, people worry about staple line disruption or leaks. And as you can see in the slide, the risk of staple line disruption or leak in a gastric bypass is actually lower than sleeve gastrectomy. It's only 3 in 1,000 reported in practice is considered to be center of excellence. So it is very good, but I wish I can say it's zero. It's not. And we do the same testing with a bubble test or endoscopy for every gastric bypass which we do. Patients who have a gastric bypass, because we reroute the intestine to the stomach, have a 5% chance of formation of ulcer at that connection. That's called a marginal ulcer. And there is a way to minimize the chance of that ulcer formation. And the reason why I'm saying that, because we know that patients who smoke and/or patients who take a lot of non-steroidal anti-inflammatory medications are at the higher risk of that ulcer formation. So when patients come for initial consultation or to the seminar, we start the conversation about the need for cessation of smoking and advise them of the change of the medications needed so we can minimize the chance of the ulcer formation. Gastric bypass also can cause unpleasant constellation of the symptoms called dumping syndrome, which is symptoms of crampy pain, nausea, sometimes vomiting, and diarrhea. And unfortunately, it is what I call self-induced and induced and brought up upon eating sugary foods or too much sugar. And gastric bypass is known to cause that side effect. And it leads to patients changing their behavior and avoiding the foods which can cause the dumping syndrome. So therefore, it's a very powerful tool to minimize the chance of weight regain if we reach for foods which are too high in unrefined carbohydrates. And again, with gastric bypass, vitamin supplementation will be necessary, and amount of supplementation will be determined by the blood work done on a every 3-month basis first year and once a year thereafter. Additional complication possible with a gastric bypass compared to a vertical sleeve gastrectomy is possible twisted intestine or internal hernia. Since we are rerouting the intestine, which normally resides in the pelvic area, to the upper stomach area, the intestines, which are very mobile, can twist around and herniate through possible spaces, creating a twist. And that possibility of that complication is approximately 5%. If that was to happen, a patient may need an operation called laparoscopy and reduction of the hernia. Procedure usually is done as an outpatient procedure. If it's properly recognized and treated in a timely manner, it is not life-threatening. But this is distinct different to vertical sleeve gastrectomy, where we do not reroute or manipulate intestine at all. So most likely, internal hernia would not happen with a vertical sleeve gastrectomy. A lot of times, patients ask questions about recovery time and how soon can they return back to normal activities and, more importantly, work. So different procedures, as you can imagine, have different expectations of that time frame. But generally speaking, that time frame is 1 to 3 weeks. And everybody is different in their pain tolerance or pain threshold, and we will guide them carefully through their process. And I generally recommend that patients for non-stapling procedures take 1 to 2 weeks off, and for stapling procedures to take 2 to 3 weeks off, because it's not just the pain from surgery which will hinder their return to work. It's a need to change the way we interact with food, how we exercise, and you're better off practicing that at home, not when you go back to work and the work precedent takes over. And unfortunately, that can lead to struggle with your improvement from weight loss surgery, and therefore work will struggle and suffer as well. The good news, however, that regardless of the procedure chosen, patients typically will lose about 10% of their weight in the first month after surgery. So typically for somebody who is between 250 and 300 pounds, I would expect that they would lose 25 to 30 pounds in the first month alone, and you can imagine how much improvement in their medical conditions we can expect from first month alone. After that, with the stapling procedures, the expectation is 2 to 4 pounds a week for the first 6 months, and for the band, as I already mentioned, 1 to 2 pounds a week, period.
I'm not as tired anymore. I seem to be able to accomplish more things in a day. I can do more things with my son. My back pain is not as bad as it was in the beginning, because I am working out 3 times a week with a trainer, and these are the hardest workouts I've ever had in my life, and I'm surviving them. That's incredible. Before, after my fall that I suffered, I had problems with swelling joints, swelling ankle, not had any swelling, and I think I can contribute that to the weight loss.
I was on medicine daily for diabetes. I was on 6 or 7 different medicines for my different asthma problems, my different joint pain. Now I'm on one medication, and it's not for diabetes, and it's not for asthma. I just take something to control allergies now. That helps financially greatly, but it gives you just a better overall sense of well-being. And I think to be healthy, to be truly healthy, you have to be healthy physically and mentally. So the two work together, and it just even gives you more of a boost, and you can just get so much more success from it. I
had all kinds of problems. I was on 2 blood pressure medicines. My blood pressure now is down to normal. I was on an antacid because I had acid reflux from the pounds of sugar I was eating. I had sinus pills because I had the CPAP. I don't have to use anymore. I don't have sinus problems, so I'm through with the machine.
It's changed dramatically. My life has changed so much for the better. I feel like a person again. Little things like getting on an airplane and flying. I just feel like a person again. I love shopping. I love hugging my children and running and playing and walking and all the things that I wasn't able to do for such a long time. I just feel like a person.
The next slide is a very important slide, and if you recall, I promised that I will show you that slide to you after the presentation to emphasize the resolution of those medical problems with a weight loss surgery. So for those of you who have obstructive sleep apnea, the good news, you can expect them to go away or improve between 74 to 98% of the time. Those who have diabetes, 82 to 96% improvement or resolution. High blood pressure, 62 to 70% chance. Those of you who suffer from migraine headaches related to being overweight, 57% chance resolution. Degenerative joint disease and arthritis, 40% chance of improvement. Depression and anxiety stemming from obesity, 47% reduced or improved. Acid reflux, reduced or improved between 72 to 95% of the patients. Overall metabolic syndrome resolves in 80% of the patients. For women who have what we call polycystic ovarian syndrome or suffer from infertility, we can expect 75% resolution or improvement, and therefore the families may have fertility resolved and healthy babies can be born. And we had in our practice many occasions to celebrate that. Overall, my favorite part of that slide is 95% quality of life improvement, which is tremendous. And no medical management, no pills, no diets alone long-term can match that. And I'm very proud to be able to help my patients to get their life back. We get into the summary part of my presentation. So let's talk about how do we decide which procedure is right for you. Obviously, This is not a decision I take very lightly, and we decided based on the multitude of factors: the patient's age, patient's health risk, so-called comorbidities, how much weight you need to lose, how fast you want to lose, what kind of lifestyle you lead, what kind of eating behaviors you have. All that factors into that decision. But at the end of the day, this is not a decision I make alone. This is a decision made by a team, including you, your family, dietitian, behavioral counselor, and of course, my job is to make sure you pick in the right procedure and support you regardless of the choice you have made. So, are you ready to make the next steps? Because if you are, I can tell you how simple it is to move on and proceed. And we tried to make it simple because we understand that it wasn't an easy decision for you to actually attend the seminar, whether it's online or in person. So we tried to emphasize what we call a one-stop shopping approach. Pre-surgery, we know that you need to engage in dietary, behavioral, exercise counseling, and we try to help you by providing those counselors readily available to you, not just a surgeon, for a consultation. If you want, we can help you to make those evaluations for the same time. So when you come to see a surgeon, you can also ask, can I see nutritional counselor or dietitian or behavioral counselor? And if that's available to you, I'm sure you'll be very happy, because you will want to take less time away from your work and your families and more time to healthier, better you, and move faster in that direction. And we can make it available to you. All you have to do is say, I would like to do that. We also offer free support groups, sometimes twice a month, because they're very popular. And that will be a good place to attend and listen and to hear other patients who already been through what you've been through and already had surgery, and you can make sure that the choice you're making is the right choice for you as well. And we try to make it fun, not just a routine, and we exchange recipes, suggestions for exercise. So we understand how difficult it is sometimes to make the first steps, and we try to make it easier for you as well. The next slide shows the key personnel of our program. I'm a director of the program, and the slide lists our coordinator, our insurance representative, and our secretary as well. So all those people are there for you. We welcome you to call, email, and come, and we'll be glad to help you and make it easy for you to become healthy and lead a healthy lifestyle. The last slide, which I usually show, is the slide which sometimes the questions come up in a live seminar when patients attend the seminar. So I will answer kind of very briefly. Sometimes women, especially younger women, ask, can I get pregnant? Or when can I get pregnant? And of course, the answer is yes. Unfortunately, when people are morbidly obese, it's sometimes difficult to get pregnant, or pregnancy will be labeled high risk. On the contrary, once you lose weight, the pregnancy will be normal and the baby will be healthy as well. All we ask you to do is wait approximately 12 to 18 months. That's the time of most rapid weight loss. So all the metabolic adjustments in the body take place, and there's no vitamin deficiency or nutritional deficiencies, and therefore there's no risk for the mother or for the baby. After that, pregnancy is absolutely normal, and we welcome it for women of childbearing age. Vitamins. I think I emphasized enough that every procedure, patient will be required to take vitamins. So therefore, start taking the vitamins now. How long does the band stay? For those who want band surgery, patients sometimes ask. And I think it's clear that the band is designed to stay in the body for 30, 40 years, as long as there's no complications. If there are any complications, of course the band needs to be removed, but the material of the band has been made durable and would not disintegrate for 30 or 40 years. Some people had prior surgeries. People have gallbladders removed, patients have appendix removed, patients have tubal ligation, hysterectomy, bowel resections, what have you. And some people think that if they had prior surgery, they cannot have laparoscopic weight loss surgery. And that is absolutely not true. Most of the time, all it means that you may have some extra scar tissue in the abdomen, which we may have to separate or free before we proceed with weight loss surgery. But typically, that does not mean that you would not be able to have weight loss surgery altogether. Some people say, I'm allergic to latex. I'm very sensitive to latex. Can I have the band surgery? And the answer is yes, you can, because band is not made from latex. Some patients say, well, what if I have band surgery and I try it and it's not working for me and I'm not losing the weight, or if there is a complication? Can that band be then removed and converted to another operation, such as sleeve gastrectomy or gastric bypass? And the answer is absolutely. Not only it can be done, but it can be done laparoscopically, and if it's done properly, there will be no higher complications comparing to doing those procedures as a first stage procedure. So therefore, we say the answer to that is yes. It shouldn't be taken as a recommendation to do the band, see what happens, and do other procedures later, because insurance companies would not just automatically pay for it. But if there's a medical reason to have the band removed, it can be safely converted to another type of weight loss surgery. Sometimes people ask, is gastric sleeve surgery reversible? Or is gastric bypass surgery reversible? And I think if you paid attention to today's seminar and you saw those video animations, you realize that sleeve gastrectomy is not reversible in the sense that that portion of the stomach which was transected and removed cannot be brought back. It doesn't need to be reversed, but nevertheless, it is not a reversible operation. On the contrary, gastric bypass is reversible for medical reasons, because the portion of the stomach which has been excluded for during the procedure is still there, still secretes its nutrients, still has its blood supply, and therefore, if medically necessary, gastric bypass can be reversed. I think I came to the conclusion of the seminar. I hope that you found today's lecture productive, learning, and educational, and I'm looking forward to seeing you very soon. Thank you very much. It was a pleasure speaking to you.